Hi everyone, my name is Fiona Young and I'm the Marketing Manager for Flen Health. Firstly, I would like to thank you all for joining us today on our Diabetic Foot Ulcer in Practice webinar with Alison Musgrove. Alison is an Advanced Podiatrist in Diabetes and Research and has over 25 years experience in foot clinic. I will introduce you to Alison very soon, but before I do so, I just want to go over a couple of points with you with regards to your attendance certificates. So if you registered with us via the email link, you do not need to do anything. You will automatically receive your certificate via your email after the webinar. If you've been passed the link through a friend or a colleague, then if you could go into the messaging service afterwards, there will be a link in there, complete the registration, and we will ensure that you receive your certificate shortly after the webinar. Last but not least, we really would like you to ask questions, so please don't be shy. Post as many questions in the messaging service as you would like to. Alison will endeavour to answer all of these questions as best she can and as many as possible. After Alison's presentation, there will be a short product presentation by a Flen Health RBM, Johnny Boyne. Johnny's been with the company now for 5 years, and as I said, it will be a product presentation on the use of Flaminal in general practice. He will also talk about the Diabetic Foot Ulcer packs, and he will also discuss the Pass It On campaign. So again, thank you all for joining, and I will now hand you over to Alison, and please enjoy the presentation.
Thank you, Fiona, that's lovely of you. I'm going to just get the screen up so that I can start sharing with you guys. It's great of Flen Health to invite me to speak to people that I don't actually live or work with. It's fantastic, albeit that I can't see you. It's nice to know you're out there. As Fiona said, I'm Alison Musgrove. I'm an Advanced Research Podiatrist and I work in Nottingham in a rather busy MDT clinic in secondary care. We see up to 120 people a week, and I've worked in this clinic for going on 25 years now. Flen Health kindly asked me to speak about diabetes and foot ulceration. Being able to access an audience like this is just amazing, and I'm sure you've all seen figures related to diabetes and foot ulceration and the big burden it is on the NHS, but more importantly on the people who suffer from this condition. And with 4 million people currently estimated to be diagnosed with diabetes in the UK and rising, we can see that this problem is going to be ever increasing. Last year, we definitely saw an increase in hospitalisation, and we're thinking amputation related to diabetic foot disease, sadly. We're looking into the reasons why this has happened. We've got the data now, so we can start investigating, but I suspect, as you will, it's largely due to the issue of people staying away from hospitals due to COVID. People were reluctant to come in to ask for help, and they suffered in silence. And this was especially clear in foot ulceration, when it often goes unnoticed and unrecognised because of their neuropathic status, their lack of feeling. However, what hasn't changed are foot ulcers themselves and the guidelines that go along with them. And this is what NICE says about managing foot ulceration, that it should be referred within 1 working day to a multidisciplinary foot care service or foot protection team. Now, I know we all work in different areas, we have different referral pathways and different referral criteria. If only that weren't so, we'd probably have a lot more early referrals for foot ulceration. And we do know also that the reason that these MDTs, or these multidisciplinary care teams, work so well is because of the sort of pathological problems associated with diabetes, and especially diabetes and feet. And you can see here sort of like a diagram of what a multidisciplinary team would usually consist of in the country. So we have 200 of them around the UK, and they're composed variously of these different healthcare professions, but they all deal with these various problems of diabetes and how it affects the foot. What we also know is that from a national diabetes foot audit, which is ongoing, this collects data from all specialist departments dealing with diabetes foot disease, that fewer than 40% of cases are referred within 1 working day for various reasons. But we also know from this diabetes foot audit that it does impact on people healing up in 6 months and being alive at 6 months. So we can see here quite a nice diagram that shows the factors that go into implicating if somebody is alive and ulcer free 6 months from referral to a specialist team. And time to referral is quite a big factor. Now, based on this, Flen Health have come up with an information leaflet. Their idea was to pass this on to people such as yourselves working in primary care. It was designed by us, and it was designed by myself, Paul Chadwick and Wendy Walker, who are all specialists in diabetes, and it was designed as a sort of more like an aid memoir. Most of the things I'll talk about today I'm very, very sure you'll have heard of before, and this is just revision. There may be some aspects of care that you'd like clarification on, and that's why we're enabling the chat at the end of it to hopefully answer some of those questions. So the acronym itself, Pass It On, was come up with by the 3 people I've just mentioned, and this is what I'll base the session on today, going through these initials and basically saying what they indicate, how it could help you in your practice. I may deviate a little bit at some points to be able to give out even more messages. I hope you'll forgive me for that. And we'll start with the beginning with P, presentation. So, as you all know, foot ulcers appear in many guises, or in different places on the foot, looking differently, smelling differently in quite a lot of cases. What we didn't put on the thing was that this often occurs on a Friday afternoon late when you want to get home for the weekend, but we can't really do anything about that. Moving on to A, the assessment of them. Sort of location of them can give clues to how they happened. We need a full assessment of the location of them, then the appearance of them, the surrounding tissues, the general sort of state of the foot, and if you can, how long this wound has been present for. As we'll come on to later, lack of feeling makes this hard in some cases. So the cause of it can be pretty obvious, and the biggest cause of diabetes foot ulcers becoming a problem is the aspect of neuropathy in diabetes. And this is caused by blood sugars being high over periods of time, damaging those nerve endings. It's quite easy to see why this person has got the problem, but sometimes this lack of feeling isn't obvious. And if someone is known to have diabetes, as you'll all be aware, they have a test every year to assess if they are losing sensation in their feet. And this is performed using a monofilament. And I'm sure you've all seen this. And I know when I first started out that this monofilament test was carried out on 10 spots on each foot. Took a long time. Thankfully, things have reduced now. We know that neuropathy is distal It occurs in the toes first. It occurs in the longest nerves furthest away from the spinal cord, which generally is the feet. It is one of the reasons why we think that we get more foot ulcers in men than women. They tend to be taller, the nerves tend to be longer. The monofilament test is a simple test, it's a bedside test. However, having said that, I have seen very unusual ways of people using the monofilament, and I must say this generally happens in doctors' practice rather than nurses. Nurses generally tend to be a lot better at it. The nylon fibre of the monofilament mustn't move on the foot. So I've seen particularly junior doctors stroking the bottom of the foot with the monofilament. This stimulates the wrong nerve endings. What you're looking for is lack of pain sensation, and stroking the bottom of the foot doesn't initiate that. We have people who appear in the clinic with this sort of problem, who, if you did stroke the bottom of their foot, would actually jump up on the ceiling because you've stimulated their nerve endings of the C fibres, not the fibres that we're looking for. And so what I would say is make sure that the monofilament stays in one place on the foot. If it bounces off, if it twitches, then discount that test and go again. A few more tips I've picked up from personal painful experience of this test is asking the person to look away from you, and also not asking, can you feel this? People love to please, we all do, and saying can you feel this will often elicit a response of yes when it isn't actually being felt by the person. What I do is ask the person to look away and tell me when and where they can actually feel the monofilament on the foot. So is it the left foot? Is it the right foot you're looking for? Is it the big toe? Is it under the big toe? And this does get a bit better response. I'm not saying it's foolproof, but it will give you some indication of whether somebody is lacking feeling. And if any one of these spots missing indicates that is so. So that's neuropathy. It's a big part of development of foot ulcers. If somebody can't feel something, and I'll keep saying this throughout the presentation, if they can't feel something, they don't know to stay away from what's causing the problem. We may not think it sometimes, but pain is a gift. It tells you when something's wrong and it tells you to avoid it. And without that gift, all sorts of problems can happen. It's very important that you actually tell the patient themselves what you'll find, why you're doing it and what the findings are, because then they'll at least have some understanding as to what this test is showing them and what it means for them going forward, the fact that damage could be occurring without them knowing it. I had a lovely patient who I used to see who used to tell me that he treated his feet like pets. So they couldn't tell him what was wrong, so he had to take extra special care and monitor them closely in order to keep them healthy. Bless him. So that's neuropathy. The next thing we come to is probably a biggie in not only in making ulcers hard to heal, but also in diagnosis, and that's a vascular assessment. We're all asked to do them again annually if somebody hasn't got a problem. And the diagnosis of peripheral arterial disease in somebody with diabetes is quite a tricky point. And I put this slide up to show you just how there is no consensus of opinion as to what the best test is. Generally in primary care and in podiatry clinics and GP surgeries, you've only got your fingers to be able to feel the pulse. And pulse palpation is important because this can actually exclude peripheral arterial disease. So if you're feeling these pulses and you can feel the blood flowing, you can feel the pulse itself, all well and good, it's very unlikely that arterial disease will be present sufficiently to necessitate hospitalisation or immediate concern. But we all know that is in a lot of cases in our population of patients very difficult due to things like edema. Pulse palpation can be very hard in people with any leg swelling whatsoever. And so not finding a pulse, again, doesn't mean they haven't got arterial disease. And if you have got access to a Doppler or specialist equipment, then obviously please do use it. What I would say is communicate with your local teams where you would refer people to, just to know what sort of tests they'd like to hear you done on somebody. Maybe pulse palpation is all they need anyway. We can go on to doing Dopplers to listen to waveforms, whether a pulse has a monophasic, biphasic or triphasic waveform, or using it in an ABPI. But these become very time consuming, and when you've got somebody in front of you with a newly diagnosed diabetes foot ulceration, it's perhaps not the place in your remit to do that. So use what you've got is my message on that one. And obviously there's exceptions to every rule, and you can see here there's quite clear indication that the main circulation is actually very good. You can actually see the hairs on the top of the foot, so that indicates that there's probably enough blood supply in the major blood vessels. However, what's happened here is that a portal of infection, an infection has got in there, it's swollen the local tissues, and it's actually cut off the capillary blood flow. So you're starting to get dying off, you're getting necrosis of the tissues in that area. But again, that doesn't need any fancy test to tell you that that is an emergency and needs immediate action either via an A&E or a one-stop clinic, depending what you have access to in your area. And another thing I would say, and again this generally applies to GPs rather than nurses, is please look at both feet together, and not only look at them but feel them together. Our hands are very good at detecting temperature differences, but they'll only do that if they've got something to compare it with. So looking at these 2 feet, you can see on both people, although on the left perhaps more subtle difference in colour, on the right more acute differences, but definitely differences, and only by seeing both feet together would somebody know what was normal for that person. And you know, it doesn't take long to take both shoes and socks off and do both feet together, which I'm sure, like I say, you all do. So we've already spoken about the specialist aspect of diabetes foot care, why people need to be referred to them, and we've seen the guidelines that follow them. However, as I say, everybody works in different areas, we all have different referral criteria, and there are local pathways and protocols to follow. Again, communication is very important with these teams, and if you can, send photos to people. We've been using these modalities of care a lot more in the last year, not only through healthcare professionals sending us photos, but also through patients sending them as well. Early specialist referral is advocated. In Nottingham, we fought long and hard to have every healthcare professional refer to the diabetes foot team, not just GPs, so people no longer have to go through a GP. Still we get delays in referral, and we do try and look into what we can do to help facilitate people to refer early. Personally, I'm still working on those people who've already had a foot ulceration being able to refer themselves into the diabetes foot clinic here in Nottingham. But this at the moment is deemed, what should we say, a step too far, and it's not come about as yet, but I'll keep banging that drum. People who've had a foot ulceration, they are the biggest group of patients who are likely to develop another one. So it stands to reason that if they're given direct access to these sort of services, we do find that they tend to present earlier and with fewer problems. Next we come to my favourite aspect of diabetic footwork, and that is solving the problem. So solving what's caused this problem. We've already seen that lack of sensation can lead to devastating conditions that just people aren't aware of. Often their first knowledge of a foot ulcer is the wife screaming at them behind them as they're trailing blood along the carpet, because foot ulcers often develop underneath the sole of the foot, not somewhere you generally look at on a daily basis, and they can go unnoticed for quite a long time. Being able to remove the cause of the ulcer as soon as possible is important. If somebody came into a clinic with a shoe that was obviously the cause of the rubbing of the foot, as it often is on the tops of feet, on the sides of feet with injuries like this, it's important that you start the conversation early about have they got anything else that they can wear just in the meantime until they can get the pressure off and get seen by a specialist to be able to manufacture something more appropriate. So even if it be, dare I say it, cutting a hole in their slipper to offload this pressure, it's quite important, because the longer they walk around in the shoe or the footwear that's caused the injury, the more likelihood that this will worsen. And people come into the foot clinic with the same shoe that's caused the pressure on the area is quite common. But equally, if somebody can't feel a rub on their foot, they're very unlikely to concede to the fact that they need to change this expensive pair of shoes that they bought only last week for something as tatty as a slipper with a hole in it. As offloading is a contentious topic with people. Very often we see in diabetes foot the deformities that are caused by the nerve damage. So it's not only lack of feeling and lack of sweating, which is another problem. It's also this foot deformity which gradually occurs over time, perhaps quite insidious onset. People don't notice that their feet are getting more high arched, that their toes are becoming more clawed. And this is due to those little small intrinsic muscles in the feet. There are only a few in the feet that actually originate and end in the feet. But when the nerve supply to those is damaged or it becomes non-existent, the toes start to actually retract and claw, and the foot takes on this high arch appearance, where you can see by that the very high arch foot that certain areas will overload more pressure than others, and frequently it's that first metatarsal area that gets all the pressure. Another aspect to this is that you and I, when we walk, we know where our feet are on the floor. Somebody with neuropathy, when they're walking, relies actually on the vibrations of their leg to know when their foot's hit the floor. Consequently, the thumping of the ground, the heavy gait, will be quite devastating to tissues on these areas that are overloaded already. Take into account and add to that the fact, as I've already said, that men have longer limbs, they tend to be heavier, and their nerve endings go first. Then this all sort of adds up to the perfect storm of the skin breaking down and being unable to heal. In order to address this problem, we have to first sort of solve the problem of what happened, and I've just got a few examples here of notable cases that have come in over the past couple of years to our foot clinic, that gives you an indication of how tricky it can be to ascertain what's happened, when quite frequently our patients will just say, well, I just woke up in the morning and it was like that. unlikely, but that's the first they know of it. This first chap, well, he had a dressing on that obviously we advise people not to go in the bath. He'd done the usual trick of tying a plastic bag around his foot with a bit of masking tape at the top of it. Unfortunately, the plastic bag was not suitable. It had holes in the bottom of it, and so the dressing got wet. And he decided that to solve this problem, he would use a hairdryer to dry it off, the resulting cause being quite a nasty burn to the dorsum of his foot there. This next chap was a bit tricky. He had these wounds on both feet. These are actually when they were healing. They were quite aggressive sort of like areas when he first came in. We could not work out what had happened, and neither could he, until he just happened to mention to me that he'd been away to his sister's new apartment in London, where he'd enjoyed, before lockdown, a nice meal with her. And I happened to mention, did the flat have underfloor heating? And yes, it did. People with diabetes, their distribution of heat tends to be affected because of the neuropathy, we think, and they don't diffuse heat across the whole of their foot. So their blood vessels don't react properly, and the heat stays very localized, so that a heat source that you or I wouldn't have bothered can actually burn the skin of these people. And this was under both his feet, and it was due to his foot being flat on the floor on top of this underfloor heating. The next chap, I'm afraid he didn't read the signs in his very posh hotel spa, which said do not sit near the steam vent of the steam room, and he was busy chilling out with his wife, and the steam was busy burning the skin off his foot. That took quite a long time to heal. But you can just see the importance of trying to get to the bottom of these and making somebody aware of what might happen again if they're not fully aware. I mean, I am just going to deviate here because this isn't really diabetes and foot ulceration. However, it is a big problem in terms of morbidity and mortality in diabetes foot disease. And you may, I'm sure, have heard of it, CHARCOT foot. It's not common. You're probably more likely to come across it when it's actually inactive and the foot's deformed than when it's actually active. However, diagnosing an active CHARCOT foot is absolutely vital. There are a few signs that can indicate that this may be happening. Unilateral foot and leg swelling. It tends to be warmer, again, that feeling of both feet at the same time. It's sometimes inflamed and red. And about a quarter to a third of people will remember some form of trauma to their foot. Again, because they have neuropathy, they may not have been aware that this had happened. However, a trip, slip, fall, bit more exercise than usual, particularly going up or downhill more than usual. They have to have neuropathy, so doing the monofilament test is very useful in this case. And it may be painful in a foot that otherwise can't be felt. And what's going on here is quite a pathway that's at the moment remains very shrouded in mystery. We don't really know why it happens to some people rather than others with neuropathy. But what happens is the inflammation pathway within the foot and then consequently the bones goes a bit haywire, so that the bones start actually breaking down. So the osteoblasts that build the bone in the foot kind of take a rest, and the osteoclasts that break it down all the time in all our bodies go a bit on a party and break down far more bone than they should. And this leads to horrendous consequences in some cases. this was a chap who came to us with a very late diagnosis of CHARCOT foot. By this time, the damage had already been done, and the bones, as you can see underneath the foot, were actually very close to the surface of the skin. You were never meant to walk on that area, so they pierced the skin, and the ulcer had already occurred. We think that's his navicular had shot up there, and he actually only came to us when the hole appeared in his foot. He'd been suffering from this swollen limb and foot for about a year, meanwhile being treated for the usual things that CHARCOT gets mixed up with, which are very important to treat and very important as differential diagnoses. So mainly infection and DVT, and if it's been going on longer, lymphedema, so sprains, fractures, gout. It takes a while to show up on X-ray, these changes, when they're early, so we tend to MRI. I don't expect anyone, because it's very difficult to diagnose CHARCOT foot, to come up with a definitive answer of it. That's not, even experienced clinicians, even we miss it in CHARCOT feet. However, we do have a strong suspicion for it, and without that strong suspicion, I'm afraid it's never going to be picked up, and you know, things like this will keep happening, I'm afraid. So that's a bit of an aside from diabetes foot ulcers, but quite an important one. As with that sort of condition, but as with all the conditions, we do need to offload, and this is what makes foot ulcers so different to leg ulcers and ulcers on other parts of the body, is that basically, you know, generally people need to walk, and any walking will cause pressure on the foot, and so we have all sorts of fancy equipment and modalities for offloading. Getting someone to wear them is a whole other topic, and I'll save that for another time. But in the foot clinics, we have access to plaster nurses, to orthotics, and to a range of temporary devices like the top left, which may not be available in primary care, but they are quite a cornerstone of treatment of diabetes foot disease. We come on to infection and treatment. So infection is a major complication, as you will all know, of diabetes foot disease. 80% of amputations are preceded by a diabetes foot infection, which is an awful lot. So by far and away, it's the biggest cause of amputations above any acute vascular problems. Because when breaks in the skin happen on their foot, they're so close to the surface of the bones, and soft tissue infection is so prevalent in diabetes because of the high blood sugar levels, because it's a foot, and feet generally aren't the easiest places to keep clean. Infection will flare up and become critical quite quickly. The difference in 24 hours can be pretty amazing, and so it's important that we treat infection swiftly but also appropriately, and I say appropriately because of the increasing knowledge in antimicrobial resistance. So I won't dwell too much on swabs. If anybody wants to ask about them in the Q&A session, that's absolutely fine, but we don't use them in foot clinic to diagnose infection. We use the classic signs and symptoms of infection, which again can be masked due to diabetes, particularly if they've got peripheral vascular disease on top of neuropathy. Very difficult, but generally it tends to be experience and the look and the non-healing nature. We may order x-rays to see if there's osteomyelitis. We may do deep tissue samples or bone samples, but generally we don't swab. If you want to know an organism, the best way to do that is by these deep tissue samples. If you want to know it's infected, the best way to do it is to go by the signs and symptoms. And the IDSA, the Infectious Diseases Society of America, show which infections should be treated with antibiotics, so the mild, moderate and severe, and how they should be treated. So the most likely infecting pathogen, which in the UK is far and away Staphylococcus aureus. You will have also known local resistance patterns, so please refer to your local guidelines if there's anything that's going on there that you know about, that you should be aware when giving antibiotics. We generally deal with, if somebody's not penicillin allergic, flucloxacillin at 1 gram rather than 500 milligrams QDS, and in foot clinics they may give sort of something like coamoxiclav 625 milligrams TDS. So we have a range of antibiotics that we can give out, and we generally treat empirically, as you do, I'm sure, in primary care, for what antibiotics are most likely to work. We also have to again take into consideration how much of that drug can actually get to the foot. And it's certainly in vascular disease, this may necessitate intravenous antibiotics as the antibiotic of choice regime. In somebody with pure neuropathy, orals usually do the trick. It will be a different course for soft tissue than it would be for bone. So if patients are coming in saying, well, I've got 6 weeks of antibiotics, it's most likely that they've either been diagnosed with osteomyelitis or it's strongly suspected by the specialist team. Topical antimicrobials are becoming more used because of the antimicrobial resistance and where antibiotic penetration tissues are poor, it can be a first line sort of defence before people are seen in secondary care. So when there's no signs of infection but bacterial bioburden or this biofilm, which I'm sure you've all heard a lot about, there's some very good talks on this on the internet at the moment about the biofilm. I will say that it doesn't matter what you put on the wound, if this biofilm is present and the dressing doesn't disrupt it, then there's no chance of that wound healing anytime soon. We, as podiatrists, have our scalpels and our forceps, and we mechanically debride the wound to bleeding. So we disrupt the biofilm, we remove it, but there are products out there. There are, other ways of doing this rather than mechanical and surgical debridement. If it's not too heavily burdened, then all of these are appropriate. But the biofilm actually stops the neutrophils getting to the surface of the wound. It's this that makes the wound sort of chronic and non-healing. And you can't see them, they're difficult to see, but I think with most wounds that have gone on for more than a couple of weeks, it's likely that they're going to be there. So we come to the last of the pass it on acronyms, the on bit. What to put on a wound? Well, we all know that firstly will do no harm, so we wouldn't put anything on it that would harm a wound. And I would say that's particularly the case with this picture on the left here, this necrotic, dry, gangrenous toe. No amount of fancy dressing will ever heal that, and the best thing to do is keep it dry with a simple dry dressing that's monitored regularly. Nothing occlusive, because if that becomes macerated, the chances of infection around those wound edges is pretty high. We come to then controlling the exudate, so almost treating foot ulcers like your house plants. They don't need to be too wet, because then they'll go and exudate. The exudate will sit on the perilesional skin and macerate that and cause problems there. Equally, having them too desiccated at certain stages will also be a problem and delay healing. So we see the gangrenous toes are cacti, no water. And then we see other stages of wounds, which you will all be more than aware of, probably more than I am, because you're the people who see the wounds in between dressing changes. What I would say is that putting a wound on to absorb exudate is fantastic. However, feet, as I've pointed out before, are quite different to other wounds. They still need to fit in footwear. So having bulky dressings that means you don't have to change the dressing quite as regularly can actually be detrimental, because it can increase pressure on other areas of the foot when this foot then goes into any form of footwear. It can also, particularly over areas like that first metatarsal head that you can see on the right there, a bulky dressing can actually increase the pressure on it. It actually makes more of a high spot on the wound, and this is particularly the case if somebody's in an offloading device that was made around the wound when there was no dressings on it, or very minimal dressings on it. So that can actually increase the pressure. So I would say, sort of, you know, it's hard. We struggle with it, and changing dressings daily is a very difficult task for healthcare professionals. We often sort of include carers in training for dressings, but again, this can be difficult if somebody lives on their own. So it's just something sort of to be aware of. I'll wind up for the questions and answers now, but I'd just like to say that the practice nurses are amazing. They've been a godsend to us in recent times and in previous times. We can't care for foot ulceration without them. They are the people who see the wound most regularly, including the person themselves usually. They are the people who spot deterioration, and they really are the people best placed to reduce amputations and improve outcomes in the world of diabetes and foot disease. And so I hope some of the things I've said today will help you in your practice, but please don't hesitate to ask questions, and thank you for listening. Thank you very much. Jane, can we use neurotips to check sensation? I wouldn't. The reason being is that they are very sharp, and quite often ischemic skin in particular can have a problem coping with a neurotip. The monofilament is usually a much better idea. I'll just move down and just have a look at what. Oh, sorry. Martina, can you send some data? All right, that's for Fiona. Yeah. Oh, thank you. So thanks, Sam. Have we found shared care's worked with patients? Yes, it has. Many, particularly those who were reluctant to come in, and particularly with the access to photos of people, they've been able to send them in, both professionals and patients. So yeah, I mean, that is certainly something we'll be carrying forward into the future. An absolute yes. People. Sorry, I've not got my glasses on. That was a mistake. Are people who are flat-footed? No, no. people who are flat-footed aren't at more risk of Charcot. It is neuropathy, and it's those people with neuropathy, generally the heavier people, but not always, who are prone to Charcot. Yeah, I mean, Fiona, can you send those slides? That's fine by me. If people want the slides, that's absolutely great. This is an interesting one, Martina. How long a presentation before we refer to a podiatrist? I think basically check your local guidelines for that. Obviously, if it's a scratch on the top of the foot and it's healing uneventfully, they won't be very thankful for you sending on, and the same with diabetes foot clinics. So yeah, check locally with that. Could foot neuropathy occur in someone without diabetes? Yes, it absolutely can. And the problem there is that they have very little access to services other than podiatry and the offloading techniques. The next highest cause of neuropathy is definitely alcohol. We don't get much tertiary syphilis in this country anymore, which was a high one many years ago. But yeah, people without. How often should you change the monofilament? My answer to that one is when you get it out its case and it's bent, change it. When it has been used on, oh gosh, I'd have to look that one up. I can't remember how often you can use it in between people. I don't think you'd be doing it in one day though, those sort of things. So. But yeah, definitely if it's bent, change it. We did have one nameless doctor who actually cut off the end of the monofilament every time he'd used it to clean it. So please don't do that. They are calibrated to a certain length. So, oh, it's stopped going down now. Sorry about this. Is it ever acceptable for us to do a remote foot check? I don't think. I mean, you can check the foot as in the progress of an ulcer, but I don't think you couldn't do a monofilament or vascular assessment by photo, unfortunately. Biggest issue at current time, Sam, it is definitely people being reluctant to come in, and now we're seeing the knock-on effect from COVID is people not being able to get orthopaedic and vascular interventions done because they've cut the obviously the amount we can get into theatres has reduced dramatically, and so that really is going to be a knock-on effect, I think. It's a shame. No, we don't use, sorry, Anonymous, we don't use a tuning fork in our assessments anymore because they're very prone to people hearing the sound, and we did find that vibration was not quite as good for picking up neuropathy as sensation was. Sandy, any tips about how an older person with mobility problems can check their own feet if living alone and has no one to assist? The biggest tip I can give to them is a mirror. Put a mirror on the floor and wave their foot over it and have a look in the mirror if they can see. The problem with feet is that, and diabetes is that often retinopathy and feet go together as a problem, so it can be an issue, but a mirror is the biggest thing I could say for somebody who's not very mobile. That's lovely. Yeah, you can have a copy of the slides, absolutely. I think that's, I think Johnny's going to talk about the Flaminal itself. That's lovely. Do you think, yes, Anonymous, do you think some patients take no notice as they think you will cure them anyway? Yes, absolutely. And I think if somebody can't feel, I think if they could feel the pain, they'd be there a lot quicker at a healthcare meeting than they are. Right, I'm very aware that Johnny's waiting to speak to you, so if there's any other questions, please pass them on to Fiona. She can pass them on to me and I'll get back to you. Is that all right? But thanks for listening again. Thank you. Thanks, Johnny.
Hello everyone, thank you Alison for that excellent presentation. My name is Johnny. I work for Flen Health as a regional business manager covering Scotland and Ireland, and today I'm going to talk to you about Flaminal. I'm also going to kind of touch over the diabetic foot ulcer rescue packs that we have. I've seen a few of you in the questions asking if these packs can be sent out, so I'll go over how you can get a hold of these packs, and then I'll also just do a brief kind of recap on the fantastic work that Alison and her colleagues have done with the Pass It On project that they've been doing. So I will share with you my screen and go through the presentation with you. So before I actually start kind of going through the Flaminal aspect of the presentation, I'd just like you to kind of think about the last time a patient came in with a diabetic foot ulcer and perhaps you were worried about infection or what dressings that you could use that would be appropriate, because they can be difficult areas to dress. So if you have a think about that. So the Pass It On campaign is a fantastic piece of work that has been done. It is a simple way of remembering what to do when a patient presents with a diabetic foot ulcer. So if you let me explain again what Alison and her colleagues have done. So if we look at P, P is for presentation. So the patient presents with a diabetic foot ulcer. So they'll come into clinic and see you to kind of help treat that. The A is for assessment, and that's where you consider ischemia. You assess and document the location, size and the tissue type as well. When we move on to S for specialist, refer the patient to a high-risk foot service. We then look at solve, remove any obvious cause of ulceration, and then we look at the IT part of it. So that is check it for signs of infection and treat as per local guidelines by obtaining the necessary antibiotics immediately if you are concerned. We then look at passing it on. So we look at put on the appropriate dressing, dress the wound as per the Pass It On pathway, which I will show you on the next slide. So as you can see, the Pass It On pathway is a simple chart which shows you how you can dress a diabetic foot ulcer. Timely use of topical antimicrobial agents to the wound bed is critical to prevent the management or to manage the infection locally and avoid unnecessary systemic antibiotics. Also reduce the risk of antimicrobial resistance. So as you can see from this guide here, you've got black and necrotic, yellow slough, red and granulating, and local infection as well. So these are all part of the Pass It On campaign that we're doing, along with the diabetic foot ulcer packs as well. This is an example of the packs that I've seen some of you asking in questions to Alison. These are the packs that we'll send out. They contain literature, some really relevant case studies, some samples, there's pathways in there as well that have been devised by Dr. Paul Chadwick. We've got applicators for the Flaminal that you're using, wound guides and tear-off pads. These tear-off pads are really beneficial if you're in a podiatry setting where a patient does present to you in clinic and you may not have Flaminal to hand. So this allows you to kind of give the tear-off pad to the patient, they'll come back and we'll make sure that we kind of supply you with some suitable samples. On the next slide that you will see, this is a good opportunity to take a picture of this slide with your phone. These are all the main contacts, regional business managers around the UK. If you are looking for a rescue pack, or if you'd like to be put in contact with your local Flen Health representative, we will be more than happy to assist with you. All our contact details are there, telephone numbers, email addresses, etc. We can also point you in the direction of our website as well, where we have a whole host of information that is tailored towards the healthcare professional. So hopefully you've all taken a picture of that screen so far, and we'll move on and we'll talk about the Flaminal aspect of it. So first of all, what is Flaminal? So Flaminal, we have the two variants. We have Flaminal Hydro and Flaminal Forte. They both contain alginate. The alginate forms part of the absorbent gel, and then within the gel we have our unique enzyme system. And the product is in a class of its own, and it's classified as an enzyme alginogel. So pretty much when we break that name down, it contains alginate. The only difference between Flaminal Hydro and Flaminal Forte is the level of alginate within each composition. So Flaminal Hydro contains a lesser percentage of the absorbent alginate. The Flaminal Forte contains a higher percentage of alginate, and therefore the Flaminal Forte is for wounds with high levels of exudate, and Flaminal Hydro is for wounds with no exudate to moderate levels of exudate. The only consideration that you have to give when you're dressing a wound is levels of exudate. As simple as that. So why use Flaminal on diabetic foot ulcers? There's three main areas that we'll focus on. Those three main areas are defend, protect and improve. So first of all, if we look at how Flaminal defends a wound, it defends against infection and contamination. So both Flaminal Forte and Flaminal Hydro are antimicrobial. It's one aspect of the combined role that it does. So it defends against infection. It's a broad spectrum antimicrobial dressing, effective at killing bacteria such as Pseudomonas, MRSA, E. coli, VRE, etc. But also in terms of contaminated wounds, Flaminal can be safely used on wounds that are not clinically infected. So those wounds are at high risk, particularly the feet. There'll be other areas for other kind of clinicians that are listening to this presentation as well. So wounds are at high risk of becoming contaminated, such as sacral pressure ulcers, anything in the kind of perineum, gynae, etc. It can be safely used on the wound to prevent infection. Flaminal Forte and Flaminal Hydro both debride and deslough the wound. So it does it autolytically, and it's a nice gentle process. So if you do have patients where pain is a consideration, sharp debridement isn't appropriate, then both Flaminal Forte and Flaminal Hydro will debride and deslough all by themselves. In terms of protecting the wound, so Flaminal protects granulation tissue and the wound edges. And what Flaminal offers compared to other antimicrobial dressings is there's no cytotoxicity associated with Flaminal. Therefore, it's going to protect the keratinocytes and fibroblasts important in wound healing. So if you do have a patient that does have comorbidities such as diabetes, they may be bariatric, there are other underlying health issues, Flaminal protects that granulation tissue and therefore facilitates faster wound healing. In terms of protecting the wound edges, Flaminal will protect the wound edges from maceration as well. Moving on to how Flaminal helps improve the wound. So Flaminal removes excess levels of exudate, and they're simply designed to give you a step up and step down in exudate levels. We know that there is an optimal moisture level for wound healing. So if the wound is too dry, the wound is not going to heal, and vice versa. If the wound is too wet, the wound is not going to heal. So Flaminal is there to help remove excess levels of exudate. Alison touched on the biofilms in chronic wounds and selecting a dressing that is appropriate, that not only is going to disrupt the biofilm, but it's going to kill the bacteria within it and also prevent the reformation of the biofilm as well. And we have clinical evidence to demonstrate and show that Flaminal is an effective dressing when it comes to biofilms in your chronic wounds. So it may not just be a biofilm in your diabetic foot wound, it may be a chronic wound that you've got on your caseload that has been long-standing and it's just not healing. And a high percentage of these chronic wounds do have biofilms associated with them. Flaminal will also clean the wound bed, and you'll start to see a reduction in the wound size as well. So Flaminal prevents infection, it protects granulation tissue and facilitates wound closure. And what you can see from this diagram is a wound at different stages of the wound healing continuum. So from when injury occurs all the way through to wound closure. And Flaminal is safe and effective to use at any stage of the wound healing process. So Flaminal Hydro and Flaminal Forte offer real benefits for you and your patients. You can see from this slide here, Flaminal is flexible, it controls infection, protects the wound edges, and it's fantastic for odour control as well. So when we're looking at patients' quality of life, and if they are having to manage life with an odorous wound, Flaminal is fantastic at controlling odour, which is a small thing to help improve a patient's quality of life as well. The other aspect of improving quality of life for the patient, along with facilitating wound healing, is pain reduction as well. So if we can offer a dressing that offers pain-free dressing changes, then that is a huge consideration that we have to give for our patients, because we know that the patient comes first in everything that we do. Flaminal kills bacteria, it offers gentle wound debridement, and it's easy to apply and easy to remove as well. So Flaminal Forte against Flaminal Hydro. What you can see from this slide here is just really again highlighting when to use Flaminal Hydro and when to use Flaminal Forte. I touched on it earlier on in the presentation that the only consideration that you need to give is exudate levels. So Flaminal Hydro is indicated for low to moderately exuding wounds, and you choose an appropriate dressing to coincide with the exudate levels. In terms of the Flaminal Forte, that's indicated for moderate to highly exuding wounds. So if I touch a little bit on the appropriate secondary dressings, if your objective is to debride necrosis or eschar from a wound, the secondary dressing that we recommend for use is a film dressing. The reason that we recommend a film dressing is it offers a moister wound environment to assist with autolytic debridement. If you were to use a foam under the same kind of circumstances, it's not going to be detrimental, but the foam would do its job, take up any kind of excess moisture or fluid exudate levels, and it would just slow that process down a little bit. If the exudate levels are moderate, we recommend using a foam, something to handle moderate exuding wounds. If we look at the Flaminal Forte, because that is for high levels of exudate, and you would simply choose a dressing that would handle high levels of exudate, and that would be a superabsorbent dressing. What I'd like to highlight to you here as well is reducing the frequency of dressing changes as well. It could have a huge beneficial impact on the patient's life if they're not having to come into clinic as often and as regular, or if you're a district nurse, you're not having to go out as often and as regular as well. Again, that brings benefits to the healthcare professional as well, where we know and appreciate that time is very valuable and you're stretched to the absolute limits. So if we look at Flaminal Forte, indicated for highly exuding wounds, the dressing change we look at is every day or every other day, so we can reduce that frequency to every other day. What we're not saying though is, we're not saying put on the dressing, put on Flaminal and come back in 2 days' time. You have to use your clinical judgment to make sure that Flaminal is in situ in the wound and it sees itself through to the next dressing change. The reason being is Flaminal breaks down in the wound due to its mode of action. So as long as Flaminal is in situ in the wound, then Flaminal will be doing all its jobs around killing bacteria, gentle debridement, protecting wound edges, etc. So just to highlight, we can reduce the frequency from every day to every other day. When we look at Flaminal Hydro, that can stay in situ for up to 4 days, but similar to with the Flaminal Forte, you have to use your clinical judgment to make sure the Flaminal is in situ up until the next dressing change. In terms of ordering information, certainly here in the UK, Flaminal is available via FP10, so prescription, and it's also available through online ordering systems in the acute setting as well. So examples of that would be PCOS, ONPOS, etc. Is available from there. We do have two sizes available for the primary care setting. They come in the form of aluminium tubes, and they're 5x15 and 1x50 gram. Now, both sizes of tubes have different kind of diameters of nozzles at the end. We have the applicators that fit the appropriate size of tube as well. So if you have taken a picture of the contact details, we'll be able to point you in the right direction of your local territory business manager, your Flen representative, and we'll be able to get them sent out to you as well. In terms of summarising Flaminal, so Flaminal is versatile, it's dependable, and it's a very unique dressing that sets us aside to the other dressings that you've got that we can offer a difference in the standard dressings that you may be using. So just to summarise, Flaminal maintains a moist wound environment. So whether the wound is too dry and we need to create a moist wound environment, you've got Flaminal Hydro. And if the wound is too wet, where you have to reduce the amount of exudate, we have Flaminal 40. So they both continuously debride the wound as well. So as I touched on previously, they do that autolytically, and that will help reduce painful dressing changes as well, and also give a point of difference where sharp debridement or mechanical debridement might not be an option. In terms of reduces bacteria and controls odour, so Flaminal is a broad spectrum antimicrobial dressing which will kill a broad spectrum of different bacteria, both gram-positive and gram-negative. And then associated with infection and bacteria is odour, and Flaminal controls odour for your odorous wounds, whether that is venous leg ulcers, infected diabetic foot ulcers, or your more complex wounds such as fungating malignant wounds as well. A huge aspect when we're putting the patient at the forefront of everything that we do is Flaminal minimises patient pain and discomfort as well. Does that for a number of ways. Flaminal breaks down in the wound, so there is no need to irrigate it. We know that there's a lot of research done about over irrigation and is it appropriate to irrigate, is it not appropriate to irrigate, but what we're saying is, using your clinical judgment, you don't have to irrigate a wound as often and as regular as maybe that you're doing at the moment. And in terms of pain, there is no pain associated with Flaminal. Flaminal is non-cytotoxic, so what we mean by this, it has no detrimental effect on the healthy cells, so your fibroblasts and keratinocytes. Some other dressings, due to their mode of action, can be seen as non-discriminatory, and what I mean by that is they can't differentiate between healthy cells and unhealthy cells, where Flaminal can. It only targets the cell walls of the unhealthy cells. There's no cytotoxicity, as I said, so therefore it doesn't follow the typical antimicrobial guidelines where you have a limited 2-week review time. So you apply an antimicrobial dressing, silvers, etc. Then you have to kind of make that call after 2 weeks. Is the wound progressing the way that I want it to? Is it not? If it is, you can continue with the dressing regime. If not, then you're going to have to look at something else. But with Flaminal, you don't have that. Flaminal is easy to apply in the most difficult areas. So very relevant to Alison's presentation, where she mentioned about bulky dressings. Dressings have to be selected with the patient in mind, so the footwear has to kind of be put over the top of them as well. And Flaminal is very conformable as well, so we can cover that aspect as well. Other difficult areas to dress would be narrow sinuses, pilonidal sinuses, anything in the perineum, under aprons, skin folds, and under breasts as well. I touched on the next point previously. It has no limit to the length of time it can be used. So yes, Flaminal is antimicrobial. It doesn't follow the typical antimicrobial guidelines where you have that limitation of wear, but it is as effective at killing bacteria as well. So that just kind of makes your dressing regime and consideration a little bit more simplistic as well. And we also have cost effectiveness data where we can demonstrate reductions in hospital stays, faster wound healing, but also when you open a tube of Flaminal, as I will demonstrate, once you open a tube of Flaminal and recap it, Flaminal self-sterilises and it is completely safe to use within its 2-year expiration date. So that means that there is no wastage whatsoever. So if you do have a patient and you've got a tube of Flaminal, even if it's after 2 weeks, 3 weeks, a month, as long as it's in the expiration date, which is on the end of the box, then Flaminal is safe to use. So that brings a huge cost benefit to your trust, to your health board, for cost-effective dressings. So that is an overview of Flaminal. You'll appreciate that Flaminal is so versatile, and we do have a lot of different areas that Flaminal can be used. So please, I encourage you to kind of get in contact with myself and my regional business manager colleagues, where we can point you in the direction of your local representative who can do remote meetings, and also once the kind of restrictions permit, then we can also kind of come in and do a more detailed approach with the Flaminal from there. So that is me from the Flaminal aspect of it. I will be happy to answer any questions. So if anyone does have any questions, feel free to ask away. So let's see if we can go through them just now. So can Flaminal be used on overgranulation tissue? Flaminal can be used on overgranulation tissue. Now there is many causes of overgranulation. If the overgranulation is caused by wound bacteria or wound bioburden, then Flaminal can help facilitate that. Flaminal will not heal overgranulation. You'll have to use a topical steroid or similar. But to reiterate, Flaminal is safe to use on overgranulation, but it will not heal overgranulation. I hope that answers your question.
There's one question there for you, Alison. Do you have any tips for what us practice nurses should cover during our foot checks?
I answered it under Emma's next bit, apart from monofilament pulse checks.
Oh, okay.
I'll pop that in.
Okay, so there's a question there from Alison. If we are using it on a sinus, sometimes there isn't any there to wash out. So could this cause reinfection at the base of the sinus? So I touched on the kind of the wear time of Flaminal 40 and Flaminal Hydro. So depending on exudate levels and which Flaminal that you're using, if you're using Flaminal Hydro, that can stay in situ for up to 4 days, but you have to use your clinical judgment that it's going to stay in situ in between dressing changes. If you're using Flaminal 40, that stays in situ for up to 2 days, but depending on exudate levels, if you were dressing that wound on a daily basis, what I would recommend doing is continue to monitor that wound on a daily basis until you are confident that Flaminal is going to stay in situ until the next dressing change. As long as Flaminal is in situ, then it's going to kind of prevent infection, control exudate, protect the wound edges as well. So we have to say that you have to use your clinical judgment. and just assess the wounds. You may have to increase the frequency that you see the patient initially, but as the exudate decreases and the wear time of Flaminal stays in situ, then you should be fine. Is there anywhere I can't use Flaminal? So in terms of contraindications for Flaminal, we do advise that if any patient has any known sensitivities to the active components of Flaminal, such as the PEG system, the polyethylene glycol, etc., then we wouldn't recommend use. These are very uncommon sensitivities or allergies to have. There's very few, if any, adverse reactions to Flaminal. So that's what we advise in terms of contraindications, but in terms of location of applying Flaminal, you should not put Flaminal into the eyes if the eyes are still in the orbital cavity, and we don't recommend use for blind fistulas as well. Flaminal is advocated for external use, so anywhere that was that you may be concerned that it would come into contact with internal organs, blind fistulas, etc. That's the only places that we would not say to use it. Flaminal is completely safe to use on neonates all the way through to end of life as well. Even if Flaminal is digested, it is completely safe. I hope that answers your question, Sam. Thanks to Simon Eves for sharing the link. As well, thanks for interesting information and presentations. You're welcome. Okay, here's one from Anonymous. Is the product related to Flamazine? So it is not related to Flamazine in any shape, way or form. It sounds very similar with the Flami, but Flamazine and Flaminal are completely different products. They have nothing to do with Flen Health, Flamazine, and yeah, nothing to do with it whatsoever. That's the questions done. If anyone has any more questions, we'll be happy to answer them. No, I think that looks like it's all the questions done. I mean, certainly from our perspective at Flen Health, a big thank you to Alison and everyone involved with the webinar. It's been fantastic, and thank you to everyone who has attended. And that brings today's webinar to a close. So thank you very much.
Thank you, Alison. Thank you, Johnny.
Thanks.